Hello everyone, I'm Patricia. Today I'll talk about fertility in CAH. So here's an overview of the presentation, which includes a background of the CAH, pathophysiology of CAH and fertility, and also strategies to overcome infertility, and finally the conclusion. So Caitlin has just talked about the background of CAH, and I'm not going to get into the details again, but some key points to note: CAH is a group of autosomal recessive disorder caused by enzyme deficiencies and primarily 21-hydroxylase deficiency, which leads to an impaired cortisol synthesis. And the worldwide incidence ranges between 1 in 14,000 to 1 in 18,000 births. And there are two forms of CAH, including the classical form and also the non-classical form. And for the classical type of CAH, it presents at birth with salt wasting type or the virilization type. And for the non-classical form, it is characterized by varying degrees of postnatal androgen excess, and also sometimes the individuals may be asymptomatic. I'll now move on to discuss the impacts of CAH on fertility from various aspects. So first of all, how does CAH cause hormonal disturbances? And there are elevation of androgens and also 17-hydroxyprogesterone in CAH, in which they will interfere with the endometrial development during the follicular phase of the menstrual cycle, and preventing conception through changes in the cervical mucus, and also effectively mimicking the contraceptive effect of a progesterone-only pills. And menstrual irregularities are seen in about 30 to 60% of women with a classical form of CAH. And in non-classical 21-hydroxylase deficiency CAH, about 10% will have hirsutism and a menstrual disorder. And for most females who are adequately treated, menses are normal after menarche, and also pregnancy is possible. And regarding virilization, the classical form with severe enzyme deficiency has a prenatal onset of virilization and is distinguished from the non-classical form with mild enzyme deficiency, which has a postnatal onset. And in the classical form of CAH with severe enzyme deficiency, the prenatal exposure to potent androgens such as testosterone and also androstenedione at the critical stages of sexual development virilizes the external genitalia of the genetically females, often resulting in an ambiguous genitalia at birth. And for individuals with a non-classical form of 21-hydroxylase deficiency CAH, they have moderate enzyme deficiency and usually present postnatally with signs of hyperandrogenism. And for females with non-classical form, they are usually non-virilized at birth. So as I've just said, classical CAH can present at birth, and in girls, the enhanced ACTH level drive excess androgen production, leading to clitoral enlargement and also fusion of the labia, and presenting with ambiguous genitalia at birth, and even leading to the inappropriate sex assignment. And this is the Prada scale, which is used to classify the degree of virilization of the external genitalia. So since anti-Mullerian hormone is not produced in high amounts in CAH infants with a karyotype of XX, the uterus persists even when the external genitalia have a typical male appearance. And for individuals with a moderate virilization, female gender identity is common. And although the family may choose the baby or the kid to have a female gender, they should also be counseled that the child will determine their own gender later on when they grow up. So for severe virilization, approximately about 3% with a 46XX karyotype may be affected, and a complete penile urethra may be seen in these cases. And the decision about gender identity are more complex for these cases because of the relatively high frequency of gender dysphoria. And historically, in these cases, the child was often identified as male at birth, and the DSD was not recognized until late childhood. However, with the implementation of newborn screening, most cases in the resource-abundant countries are identified soon after birth. And the management of these children presents a complex and also difficult problem because there are uncertainties about the gender identity and also surgical challenges. And patients with virilization will have a common urogenital sinus, that is, one common opening located in the introitus below the clitoris, with the conference of the urethra and also vaginal internally, and varying degree of hypertrophy of the clitoris. So diagram A on the top right-hand corner illustrates the high conference form. In this case, the urethra and the vagina meet close to the bladder neck. And for diagram B, which is on the left lower corner of the slide, is the low conference type. And for this group, the urethra and the vagina meet closer to the opening of the common urogenital sinus on the underside of the hypertrophy clitoris. And for the surgery required to restore a female anatomy, it includes separation of the urinary tract and also the vagina, labioplasty, which involves the reconstruction of the labia minora and majora so that they have a typical appearance and position. And finally, clitoroplasty, which is the reduction of the size of the clitoris. And this is generally considered only for the patient with severe form of virilization. And the general consensus is to defer clitoroplasty until the patient are old enough to specifically request the surgery by themselves. And a possible complication of clitoroplasty is that it will impair clitoral sensitivity. And this has been reported in one retrospective study. And newer techniques such as the ventral nerve sparing approach are designed to preserve the sensation and the sexual function, but then no long-term data is available at this moment on the functional capacity of the clitoris after the surgery. So when should we perform genitoplasty? And according to the 2006 Joint Lawson-Wilkins Pediatric Endocrine Society and also the European Society for Pediatric Endocrinology Consensus Statement, it stated that the surgery should only be considered in cases with severe form of virilization, which it defines as Prader stage 3 to 5 level. And the surgery should be performed in conjunction, when appropriate, with repair of the common urogenital sinus. And since orgasmic function and also erectile sensation may be disturbed by the clitoral surgery, the surgical procedure should be anatomically based to preserve the erectile function and also the innervation of the clitoris. And the emphasis is on the functional outcome rather than strictly a cosmetic appearance for the surgery. And according to the Endocrine Society Clinical Practice Guideline published in 2010, clitoral and perineal reconstruction should be considered in infancy and performed by experienced surgeon in a center with a similarly experienced pediatric endocrinologist, mental health professionals, and also social work service. And although there are no RCT on either the best age or the best method for feminizing surgery, the recommended procedures are neurovascular sparing, clitoroplasty, and also vaginoplasty using a total or a partial urogenital mobilization. And when necessary, vaginoplasty is usually performed in late adolescence period because routine vaginal dilation is required to maintain a patent vagina. So in summary, the optimal timing of surgery is unclear, and the decision should be made collaboratively with the family after discussion of the consideration and also the clinical outcomes after the surgery. And for families considering an early surgical intervention, the following factors can be considered separately. For the initial surgery, repair of the urogenital sinus, vaginoplasty, and labioplasty with or without clitoroplasty could be considered. And for patients with a low urogenital conference of the vagina and urethra, advocates of early surgery generally recommend performing these steps during infancy or as soon as the family is fully informed and feels ready. There are no RCTs that have evaluated either the best age or the best method for restoring functional female anatomy with a separate urethra and vaginal opening. However, proponents of early surgery argue that functional outcomes are good when performed by highly experienced surgeons using modern techniques that focus on preserving the neurological innervation of the vagina and also clitoris. And they argue that the relatively poor outcomes described in some reports reflect that the surgery was performed more than 2 decades ago and also using some older techniques. And in addition, earlier restoration of the typical female anatomy helps to avoid potential complication of a confluent vagina and also urethra, for example, urinary tract infection and also obstruction of the menstrual flow at puberty. And another possible advantage for infants with severe virilization to have early complete reconstruction is that it allows the surgeon to use the excess common urogenital sinus tissue to reconstruct the anterior vaginal wall. However, for individuals with a high urogenital conference, the surgery is more complex and the outcomes of early surgery are less certain. And what about the rationale for a non-interventional approach? And there are a few things to consider in this case. First, the decision about early urogenital surgery may not be consistent with the child's ultimate gender identity, sexual orientation or desire for penetrative sexual activity, fertility desire, and also the personal preferences. And in a large meta-analysis, approximately 10% of individuals with CAH do not identify themselves as female as adults, and about 25% of those with female gender identity experience sexual attraction to women, which may influence their preferences and also decisions about their genital appearance and function as they reach adolescence and adulthood. And second, feminizing surgery can have lifelong complications, for example, vaginal stenosis and loss of clitoral sensitivity. The risk of long-term complication is not well known and likely depends on individual patient characteristics, as well as the method and also experience of the surgeon. But complications can still occur even with an optimal surgical management. And third, clitoral surgery may not be necessary at an early stage. An enlarged clitoris observed in a newborn may decrease in prominence over time with adequate glucocorticoid treatment. And there is limited evidence on the surgical outcomes. The effects of early versus late genital surgery on the psychosocial or psychosexual development or quality of life are still unknown. And nowadays, living with an atypical genital appearance may be acceptable to the child and the family because of the changing social norms and the peer support. So just now we've talked about the timing and the extent of the genital surgery. Who would require genital surgery? And females with a classical 21-hydroxy deficiency, CAH, who plans to be sexually active typically requires a reconstructive gynecological surgery. And there are various types of vaginoplasty procedure with or without nerve-sparing clitoroplasty that may be performed as an initial procedure or a revision of a procedure performed earlier. And additional surgery, plus or minus a vaginal dilatation program may be required after the surgery. And for vaginal dilation, regular dilation and adequate lubrication are needed to reduce restenosis of the vagina and also pain during sex. So what are the psychosexual impacts and associated with genital virilization? Genital virilization and the subsequent need for genital surgery may prevent vaginal intercourse and also may have negative impact on the pregnancy outcome. And dissatisfaction with sexual life due to surgical complications and cosmetic outcomes can lead to a reduce in sexual confidence and also fewer sexual interactions. And female with CAH are less likely to be in a heterosexual relationships with an increased preference of bisexuality and also homosexuality. So besides the psychological aspects, what about the reproductive outcomes? The fertility rate depends on the type of CAH, the disease control, and also the genital structural changes from the reconstruction surgery. And Castoris and his colleagues from the UK did a survey in 2009 and found that only 23.6% of the women with a classical CAH expressed a desire for pregnancy. And in contrast, in women with non-classical CAH, the desire for children is up to 50%. Another comprehensive Swedish epidemiology study performed in 2021, they found that only 25.4% of women with a classical with CAH had at least one child, which is half rate of the control population. And the lower rate was primarily due to the reduced rate among women with the short wasting type of CAH, where only 8.1% of them had a biological child. And in terms of the percentage, non-classical type has got the highest rate of fertility, followed by the simple virilization type, and the last is the classical short wasting type. And the management of CAH is complex and lasts from childhood to adulthood of the patient with CAH. And therefore, a multidisciplinary team of specialists, including the endocrinologist, the urologist, clinical geneticist, psychologist, and us, the gynecologists, is very important for the diagnosis and also the management of individual with CAH, and especially for the classical type of patients. Now I will move on to talk about the details of monitoring and treatment of patients with CAH in the preconception period. So the main challenges encountered in fertility treatments are the chronic exposure to adrenal androgen causes the disorders of the hypothalamic pituitary ovarian axis, leading to a hypersecretion of LH, and also androgen excess associated and ovulatory cycles, as well as the increased circulating progesterone concentration during the follicular phase of the menstrual cycle. And this will negatively impact the endometrial receptivity, tubal motility, and also the thickness of the cervical mucus. And in order to tackle the problems that I've just mentioned, it is important for us to provide adequate glucocorticoid and mineralocorticoid replacement to attenuate the production of adrenal-derived steroids through the partial compression of both corticotropic releasing factor and corticotropin secretion. And for females with the classical form of CAH, we aim to regulate the menses and also to optimize the sexual function by glucocorticoid replacement and to restore the functional anatomy by surgery. And before planning for pregnancy, the women with CAH and the biological father, whenever it's present, should receive genetic counseling. And Caitlin has just talked about the probability of CAH patients having a child with CAH. So just a quick recap. Women with a classical CAH may have a 1 in 120 probability of having a child with a classical CAH if the partner status is unknown. And these risks will increase if the biological father is a carrier of the gene defect. And this is a diagram showing the optimal treatment for achieving pregnancy in both males and females with CAH. And the lower half of the diagram focuses on the female patients. And in sexually active women, optimizing the treatment can result in normal fertility rate. And Caitlin has talked about the treatment in her presentation. I'm not going to go into the details again, but the basic principle is to restore the menstrual cycle, suppress the androgen level, and to normalize the progesterone level by adequate replacement of the hydrocortisone with or without the use of prednisolone. And adrenectomy should be the treatment of last resort after trying the standard ovulation induction measures. And regarding the fertility treatment, in classical CAH, most patients will become ovulatory with the routine dose of hydrocortisone, and some will require a higher dose for suppression of the progesterone of the adrenal origin. And for the non-classical type of CAH, patients exhibiting symptoms of hyperandrogenemia are also likely to benefit from some therapy, although spontaneous pregnancies without any glucocorticoid replacement have been reported up to 50 to 60% of these population. So for those patients who cannot achieve ovulation despite adequate treatment and reduction of progesterone and also androgen concentration, injectable gonadotropins or chromatin may be useful to induce ovulation. And IVF can be an alternative option for those who fail to achieve pregnancy with gonadotropin or also chromate. And after ovarian stimulation, a freeze-all strategies could be considered to avoid the additional increase in progesterone concentration by the IVF treatment. And for pre-implantation genetic testing, it can be performed to determine if CAH is present in embryos before they are transferred back to the uterus. And with this method, the parents have the option to select the embryos that are unaffected by CAH for implantation. And if the male partner is a carrier of the gene defect, PGTM could be performed to determine if CAH is present in embryos before embryo transfer. And to conclude my presentation today, both types of CAH are associated with certain degrees of infertility, and patients with CAH should be followed by a multidisciplinary team. And the causes of infertility in CAH patients are multifactorial, including virilization of the external genitalia, disturbances of the hormones, and also altered psychosexual development. And the replacement of sufficient glucocorticoid usually resolve these problems and may lead to a spontaneous pregnancy and successful ART treatment.